This video will demonstrate the step-by-step insertion of the Palindrome Precision RT-Reverse Tunneled Dialysis Catheter via the right internal jugular vein using a valved, pull-apart safety sheath. Please be sure to consult the product instructions for use included in the product packaging before using this product. Good catheter outcomes post-insertion depend in part upon proper catheter positioning during initial placement. Improper positioning of the catheter tip during initial placement can result in insertion complications, poor catheter performance, reduced blood flow rates, and long-term complications including catheter dysfunction, thrombosis, and fibrin sheath formation. Precise positioning of the catheter can be difficult with the antegrade tunneling technique, not to mention the challenge of technique repeatability with varying patient morphologies. It can be difficult to secure the exact catheter tip placement once the tunnel has already been created. Using a retrograde tunneled catheter is intended to enable more precise tip placement and exit site creation. In the event an over-the-wire exchange is required, a retrograde tunneled catheter allows for catheter exchange and creation of a new separate tunnel tract and exit site. The retrograde technique facilitates left-sided placements over the wire where the anatomy is more tortuous. The Palindrome Precision RT-Reverse Tunneled Catheter combines reverse tunneling with several unique features including symmetric tip design, precision tip technology, and a compact functional end that allows for increased visualization on fluoroscopy and X-ray, precision tip placement in the right atrium, more flexibility to accommodate varying right atrium sizes, strong flow performance, and low recirculation rates. Another unique feature of the Palindrome Precision RT catheter is the easy-click hub connection of the catheter backend and extensions to the catheter body. This provides an easy connection with a tactile click that confirms for the inserter that the connection is secure. The Palindrome Precision RT-Reverse Tunneled Dialysis Catheter is a 15 French high-performance cuffed catheter made of kink-resistant carbothane material. The catheter is indicated for hemodialysis, apheresis, and infusion and is MRI conditional. The radiopaque catheter is provided in 3 segments to facilitate the reverse tunnel insertion technique: catheter shaft with valve adapter, hub connector, and dual extension back end assembly. The attachable configuration allows the distal tip of the catheter to first be positioned in the right atrium. The catheter is then reverse tunneled subcutaneously to an exit site. After tunneling, the catheter hub and extension is assembled in place and secured to the patient. The catheter extensions are made of silicone with Ultim adapters for added durability to reduce the risk of breaking and crimping with repeated cleaning and use. In addition, the Palindrome Precision RT catheter has a unique symmetric tip design and incorporates laser-cut side slots. Dialysis lines are frequently reversed to try and maintain adequate catheter flows. The reason for reversing the lines is typically poor blood flows, which can occur from catheter occlusion or the position of the catheter to the wall of the vessel in the right atrium. This reversal of lines, however, in a staggered or split-tip catheter can potentially lead to recirculation. The unique design of the Palindrome Precision RT symmetric tip is designed to result in low recirculation, not only in the forward position, but also when the lines are being reversed. The unique side slots that are laser cut on the Palindrome Precision RT catheter are designed to reduce debris attachment, which can lead to a potential decrease in clot formation. Their edges are smooth, decreasing the likelihood of debris attachment. The Palindrome Precision RT catheter is ideally placed in the right atrium via the right internal jugular vein. The catheter can also be placed in the external jugular veins, left internal jugular vein, subclavian or femoral veins as last resorts. The right internal jugular vein is preferred as an insertion site per Kadoki guidelines. The catheter may be inserted either percutaneously or by cut-down. Items required for this insertion and included in the standard Palindrome Precision RT kit are 1. Palindrome Precision RT-Reverse Tunneled Catheter Valve Adapter Assembly. 1. Hub back-end assembly with a colored end cap. 1. Hub connector. 1. Tunneler with an additional tunneler cap. 1. 12 French tissue dilator and 1. 14 French tissue dilator. 1. 16 French hemostatic valved pull-apart safety sheath. 1. 12 milliliter syringe. 4x4 gauze sponges. 2. Telfa Island wound dressings. 2. Sealing caps. The Palindrome Precision RT catheter is available in multiple implant lengths, measured tip to cuff, including 19 centimeters, 23 centimeters, 28 centimeters, 33 centimeters. 44 centimeter and 55 centimeter femoral lengths are also available. Each Palindrome Precision RT kit is supplied with an external measuring kit containing 1. 18-gauge 1.2 millimeter introducer needle, 1. number 11 scalpel, 1. 0.038-inch J straight guidewire. The external kit components are sterile and should be used prior to opening the catheter kit to ensure that the appropriate length catheter has been chosen for insertion. Additionally, you will need prepping and draping materials, skin anesthesia, clamps, gauze and dressing materials, and a method for stabilizing the catheter such as sutures or a catheter securement device. You will also need sterile heparinized saline for flushing the catheter. Some physicians prefer to use a micropuncture kit for insertion rather than the 18-gauge introducer needle. Finally, you will need to have access to fluoroscopy, ultrasound, or X-ray to confirm placement of the guidewire and catheter. Fluoroscopy is recommended per Kadoki guidelines. When beginning the procedure, provide a sterile operative field using sterile drapes, instruments, and accessories. Perform surgical scrub and don appropriate surgical attire. Once you have prepped the patient and access site according to institutional protocol, isolate the access site with sterile drapes. At this point, you can use landmarks to locate the internal jugular vein. The true standard of care is to utilize ultrasound and visualize the jugular vein. This decreases the risk of inadvertently puncturing the carotid artery. For jugular insertion, turn the patient's head slightly to the side to expose the insertion site. Once you have identified the jugular vein or alternate insertion site, administer local anesthetic to the skin and underlying tissue at the venotomy site. Remove the external measuring kit pouch containing the measuring introducer kit components. Open the pouch and aseptically introduce the components into the sterile field. The guidewire contained in the measuring kit is marked in 10 centimeter increments and will allow you to confirm that the appropriate Palindrome Precision RT kit and catheter insertion length has been selected. The internal jugular vein can be accessed utilizing an 18-gauge introducer needle. The following section will demonstrate the use of an 18-gauge introducer needle. Flush the 18-gauge introducer needle with sterile heparinized saline. Attach a syringe and insert the needle, advancing it into the vein in the direction of blood flow. While drawing back on the syringe, aspirate a small amount of blood. Look for a dark flash of blood to confirm the needle has entered the vein. Once you see a venous blood flash, disconnect the syringe from the needle and promptly insert the flexible J end of the guide wire through the introducer needle. Failure to insert the wire promptly may lead to blood loss or air entrance through the needle. Continue to advance the wire into the vein. The length of the wire inserted will be determined by the size of the patient. Be careful to avoid passing the guide wire into the right atrium, as cardiac arrhythmias may occur. Ideal placement of the guide wire tip should be in the mid to upper right atrial location per Kadoki guidelines. Confirm proper guide wire tip placement with fluoroscopy or X-ray. Once the guide wire is in place, withdraw the introducer needle, leaving the guide wire in the vein. Be sure to stabilize the guide wire to prevent further advancement or retraction. Next, identify the tunnel tract. Place the exposed end of the marked guide wire on the patient's chest to note the desired cuff location within the intended tunnel tract. Ensure that the proposed tunnel tract lies in a smooth, gentle arc to reduce the likelihood of the catheter kinking post-insertion. Note, the ideal tunnel length is a minimum of 6 centimeters. Determine the desired exit site location by making a mark a minimum of 2 centimeters distal to the noted cuff location. Once the catheter insertion length has been confirmed, open the appropriate Palindrome Precision RT kit using a sterile technique. Remove the catheter valve adapter assembly from the kit. Flush and lock the catheter with heparinized saline using the pre-connected valve. Note, the valve adapter closes and seals when the syringe is removed, so no clamping or capping is required to lock the catheter. Remove the catheter hub back-end assembly from the kit. Note, remove and discard the colored end cap from the lure adapter. Flush and lock each extension lumen with heparinized saline, making sure to clamp both extensions. Note, to avoid air embolism, ensure that the catheter valve adapter assembly and hub back-end assembly are filled with sterile heparinized saline prior to implantation. Make a small incision at the insertion site, utilizing a number 11 blade scalpel to free any dermal tissue that may impede or kink the catheter post-insertion. To pre-dilate the vein, thread the 12 French dilator over the end of the Guidewire. Advance the dilator into the vein only as far as necessary using a rotating motion to assist passage through the tissue. Be sure to hold the Guidewire in place without advancing it further into the vessel. Repeat this step with a 14 French dilator and/or a 16 French dilator if desired. Take the valved pull-apart safety sheath assembly from the package and remove the dilator from the end of the sheath. Note, be sure to discard the clear protective sleeve that covers the sheath prior to insertion. Insert the vessel dilator onto the sheath until the dilator cap folds over the valve housing and secures the dilator onto the sheath assembly. Thread the dilator sheath assembly over the Guidewire. Caution: to avoid damaging the tissue and the sheath tip, do not let the sheath advance over the dilator. The two must be grasped as one unit. With a rotational motion, advance the assembly into the vein only as far as necessary. Ensure that the Guidewire does not move further into the vein. Once positioned, separate the dilator cap from the sheath valve housing by rocking the dilator cap off the hub. Slowly retract the Guidewire and dilator, leaving the sheath in position. The hemostasis valve will reduce the loss of blood and the inadvertent aspiration of air through the sheath. Quickly advance the catheter through the valve. To reduce the risk of kinking the catheter, it may be necessary to advance in small steps by grasping the catheter close to the sheath while inserting. Warning: ensure the catheter is filled with heparinized saline and is free of air bubbles before inserting it into the vein. Continue inserting the catheter through the valved sheath and into the vein. Confirm correct placement and catheter function by aspirating venous blood from the valve adapter, then flush 10 milliliters of sterile heparinized saline into the valve adapter. Utilizing the tabs on the sheath, double snap the valve housing in a back and forth motion to split the valve from the catheter. Holding the catheter firmly in position so as not to dislodge it from the vein, peel the sheath apart while simultaneously withdrawing it from the vessel. The sheath will separate from the catheter, leaving the catheter in the vein. Caution: do not allow the catheter to move out of the vein with the sheath. Ensure that the vein is not bleeding around the catheter. After insertion of the catheter, use fluoroscopy or X-ray to view and confirm catheter placement, being sure to position the catheter correctly in the right atrium. Confirm correct placement and catheter function by vigorously aspirating venous blood from the valve adapter, then flush 10 milliliters of sterile heparinized saline into the valve adapter assembly. With the catheter tip in the correct position, place the external section of the catheter on the patient in the proposed trajectory of the subcutaneous tunnel. Use the exit indicator line printed on the catheter to estimate the exit site. Ensure the proposed tunnel tract lies in a smooth, gentle arc to reduce the likelihood of catheter kinking post-insertion. Note, the ideal tunnel length is a minimum of 6 centimeters. Administer local anesthetic along the tunnel tract trajectory. Use the number 11 scalpel to create an incision no larger than the catheter width at the selected exit site. Use the tunneler device to create a tunnel in a retrograde fashion through the exit site toward the insertion site. If desired, bend the tunneler into a wide arc to make a curved tunnel. Ensure that the tunneler tip exits at the venous insertion site. If difficulty is encountered in completing the tunnel, do not use excessive force. Instead, use metal forceps to dissect impenetrable tissue. Once the tunnel is created, unscrew the bullet-shaped cap to expose the end of the tunneler. Be sure to retain the cap in the sterile field in case additional tunneling is required. Ensure the guidewire has been removed from the catheter lumen. Pinch the catheter tubing and apply the smooth-jawed forceps at the insertion site, firmly clamping the catheter tubing. Note, ensure the catheter is clamped at all times during this process to minimize the risk of air embolism or blood loss. When clamping, fully close the forceps so that all of the teeth on the locking ratchet are engaged. Grasp and cut the clamped catheter at the first indication mark to remove the pre-attached valve adapter assembly. Then firmly grasp the catheter near the cut end and advance the tunneler tip in short increments into one of the catheter lumens. Note, to securely connect the catheter, advance the tunneler until the catheter tubing completely covers the metal-ribbed tunneler end. Carefully pull the clamped catheter through the tunnel tract from the insertion site to the exit site. When it emerges, apply the second pair of smooth-jawed forceps to the catheter near the tunneler tip. For proper cuff placement in the tunnel tract, remove the first pair of smooth-jawed forceps at the insertion site, and then gently pull the catheter through the tunnel until the exit indicator line printed on the catheter becomes visible. Reapply the smooth-jawed forceps to the catheter next to the second indicator mark and remove the other pair of forceps. Cut the clamped catheter at the mark to trim the catheter to the final catheter length. Slide the hub snap connector onto the end of the clamped catheter tubing. Align the D-shaped metal tubes of the hub back end assembly with the internal lumens of the catheter tubing. Note, either orientation of the venous and arterial lumens is acceptable. Pinch the catheter and advance it in short increments over the D-tubes and into the locking ring so that the D-tubes are completely covered by the catheter tubing. Advance the hub snap connector, making sure to align the connector arms with the mating grooves on the hub back end assembly. Snap the two components together, making sure there is a tactile click and the connection is secure. Note, visually inspect the connection to ensure the locking tabs are fully seated. If they are not, push the connector until both tabs are fully seated. Remove the smooth-jawed forceps and confirm the correct placement and catheter function by aspirating venous blood from both the arterial and the venous lumens. Flush at least 5 milliliters of sterile normal saline into each lumen to clear the blood. Note, the priming volumes are printed on the sleeves of each lumen. Follow with a heparinized saline lock of 5,000 units per milliliter or according to institutional protocol. Clamp the extensions immediately after infusing, utilizing a positive pressure technique. Place a small amount of heparin in each of the sterile injection caps and attach the sterile injection caps to each adapter. Suture the entry site and stabilize the catheter with sutures using the extension wings at the catheter hub or by applying a catheter securement device. Apply dressings to the catheter insertion and exit sites. Confirm final catheter placement with fluoroscopy.